Interventional radiology and invasive cardiology generate nearly 13% of a hospital's revenue. Yet behind that massive financial footprint, the specialty is quietly bleeding margin under the weight of an unsustainable billing structure. This chart compares monthly denial rates. The baseline is the 5 to 8% outpatient average. Above it, interventional radiology faces 15 to 20%. Up to 65% of those rejected claims go unchallenged. The revenue is simply abandoned. Every kyphoplasty, embolization, and TIPS procedure carries its own distinct CPT codes, global period logic, and payer-specific policies. One misapplied modifier triggers a rework cycle that stalls cash flow. This persistent revenue loss stems from a structural mismatch between clinical complexity and generic billing systems, rather than a lack of staff effort. The friction begins before the procedure even takes place. Almost every interventional radiology intervention requires prior authorization from commercial payers and Medicare Advantage plans. American Medical Association data shows that practices complete an average of 39 prior authorization requests per physician every single week. That volume translates to 13 hours per week dedicated entirely to administrative paperwork, nearly a day and a half of clinical capacity consumed by securing permissions. For an interventional radiology practice, managing this requires dedicating up to one full-time equivalent staff member at a cost of $40,000 to $80,000 annually just to handle the queue. Even with dedicated staff, the approval timeline drags. 60% of these requests take more than a full business day for approval, and a quarter stall out for 3 days or more. This administrative drag directly impacts the clinic floor. 94% of physicians report that the prior authorization process causes explicit delays in patient care and contributes heavily to burnout. The prior authorization burden is an active structural barrier that caps clinical capacity, limits throughput, and artificially suppresses a practice's revenue generation. On January 1, 2026, the Centers for Medicare and Medicaid Services implemented a total overhaul of the interventional radiology code set, effective immediately, with absolutely zero grace period. More than 80 billing code changes went live simultaneously, forcing practices to adapt overnight. 16 existing codes were permanently eliminated, and 46 brand new codes were injected, bringing the total active IR code set to approximately 300. For practices relying on in-house staff, this change required a mandatory, massive retraining event right in the middle of the normal operational year, disrupting existing workflows. Coding errors on this new set trigger aggressive compliance reviews and formal audits that go far beyond simple claim rejections. Differentiating between a diagnostic angiogram and a therapeutic intervention, or correctly applying Medicare's multiple procedure reduction rules, requires credentialed, specialized knowledge that generalists do not possess. The 2026 Code Shock demonstrates that generalist in-house billing teams cannot reliably navigate the volatile regulatory environment inherent to interventional radiology. Many practice owners attempt to manage this complexity by expanding their in-house billing teams, assuming internal control is the most cost-effective strategy. The most visible cost is base salary. An in-house biller commands $55,000 to $75,000 a year, but labor data shows a 33% annual turnover rate. Replacing a staff member adds up to $30,000 in recruiting, onboarding, and lost productivity. Practices are trapped in a continuous staffing spiral. Hire a biller, absorb the cost of learning curve errors, watch them leave, and restart the cycle. Every mistake made during those learning curves carries a direct financial penalty. Reworking a single denied claim costs between $25 and $117. For a practice generating standard claim volumes at a conservative 15% denial rate, reworking those claims burns nearly $1,000 a month in pure administrative waste, before accounting for the revenue that is completely lost. The true cost of an in-house biller extends far beyond their salary. It's an economic model that consistently drains practice margins through continuous turnover and endless error rework. Solving this requires treating interventional radiology billing not as generic administrative overhead, but as an outsourced, highly specialized engineering function. The baseline requirement for this model is strict specialization. Billing must be handled exclusively by AAPC and AHIMA credentialed professionals who focus entirely on interventional radiology. To maintain operational continuity, these external teams integrate directly into the practice's existing electronic medical record system, functioning identically to in-house staff, but without the structural overhead. Duties must be strictly decoupled. Prior authorization workflows are separated entirely from the general billing queue and handled by dedicated specialists tracking the approval process. Visibility is maintained through weekly reporting. Practice owners receive dashboards detailing precise metrics on denial resolution, system throughput, and days in accounts receivable. Before claims ever reach the payer, they pass through a pre-submission scrubbing process. This catches CPT-ICD mismatches and modifier errors internally, ensuring only clean claims go out. Offloading the billing burden to credentialed operators working inside your EMR eliminates the structural vulnerabilities of the traditional practice model. Modern service providers like Staffingly take this specialization further by combining credentialed human expertise with AI-augmented workflow tools to scale accuracy. Smart routing uses an algorithmic gate to scan and sort incoming claims into specific channels based on procedure type and payer history. Next, predictive audits scan the queue. Coding anomalies are instantly flagged and isolated for human review. The financial math of this optimized system is stark. The Staffingly model operates at $399 per week per seat, totaling approximately $20,748 annually. Compared to the in-house baseline, this generates immediate savings of $34,000 to $54,000 per full-time equivalent, instantly erasing the financial drag of turnover, benefits, and retraining. Practices can bypass lengthy transitions and go fully live within 14 days, operating under built-in SOC 2, ISO 27001, and HIPAA compliance from day one. This human-AI hybrid model yields a verified error rate below 1%, a structural efficiency that has already saved more than 800 healthcare practices a combined $14 million. Surviving the escalating complexity of interventional radiology billing requires abandoning the flawed in-house staffing model and adopting an AI-augmented, specialist-driven infrastructure.